Good afternoon, everyone. Myself, Khubaib Ahmed, on behalf of Institute of Economic Growth, UNICEF and Center for Policy Research, welcome all of you to the fifth AMB webinar in the series, Increasing Financial Efficiency of Anemia Mukt Bharat, Lessons and Opportunities. I would also like to take this opportunity to introduce my co-host, who will be providing support and facilitation of the webinar, namely Dr. Naren Patel and Ms. Avi Seni. In the second session, our co-host Ms. Avni from CPR would moderate the panel discussion. Before we start the session, I would like to share some general housekeeping rules for smooth flow of the webinar. Your microphone and video system would be turned off to avoid interruptions. We would encourage participation from all participants throughout the webinar. You can use the Q&A button to submit your questions for the panelists. And the webinar will be recorded for us to collate all the questions and develop the summary of deliberations. Now, I would like to invite Dr. William Cho to welcome all the panelists on behalf of IAG and CPR.
Thank you, Kobe. Good afternoon, everyone. And I take this opportunity to welcome all the panelists and all the participants for the fifth Anemia Mukt Bharat webinar series on increasing financial efficiency of the AMB program with insights from the program in terms of lessons and what opportunities we have to further work on the issue of financing. As we all know that financing has been a very much important area for policy decisions. And bulk of the research or bulk of the discussions has been around the level of funding support as such. But I think that there is a lot of scope to actually understand financing. And it is not merely the overall quantum of resources that is needed for the sector as such, but also in terms of how it is utilized, how it is planned, what are the issues in disbursement and utilization of the funds. These are important areas where I think more evidence is needed. We have this hunch that while the budgeting as such may be low, but at that same time, we also understand that how much is being budgeted, is that utilized or not. So from that perspective, there is some encouraging evidence which I think we are finding that part of the problem also lies in our approach towards planning. And it is not per se from the point of view of the state or the center, but it is in general that there are gaps and challenges which needs to be identified. And until unless we list them out, it will be impossible or it will be difficult to actually enhance the budgetary allocations. And there are some interesting results which we are finding in this regard. So this is like one of the broad challenges that we are finding in the field of financing. But apart from that, there are several other issues which I think this webinar will aim to cover. And in that sense, I appreciate the points and the topics which are being covered through this webinar in the sense that it gives us a new window into understanding financing, both from a research perspective as well as a policy perspective, and how we can take this forward to achieve the ambitious target of anemia reduction in the country. So as such, Poshan Abhiyan has actually given a major boost to the field of nutrition, but I think it has also raised a number of issues and challenges for all the stakeholders and collaborators to work and try to make this program a successful program. So with those few words, I would request Kobeb to kindly introduce our panelists, and I would also suggest that I think soon after each presentation, we can take up the question and answer, at least a couple of them, so that it ensures continuity and flow of the webinar. And at the end of the initial set of panel, we can then have about a few questions for all the participants. So with those few remarks, I would request Kobeb to kindly start the session. Thank you, Kobeb.
Thank you, sir. Now I welcome Dr. Alok Ranjan to share his insights on the topic. Dr. Alok Ranjan has worked in areas of public health and nutrition for the past 15 years, with the last 5 years spent leading the nutrition work in India for the Bill and Melinda Gates Foundation. Since 2017, he is additionally leading Foundation's nutrition work in Bangladesh. From 2018, he is also looking after the nutrition work in South Asia. And from 2019, he is also supervising the nutrition work by the Foundation in Indonesia. Dr. Alok is a medical doctor and has a postgraduate degree in preventive and social medicine. Dr. Alok, I would like to invite you to start your presentation.
Thanks. Can you hear me? And
yeah, you're audible. Yeah.
Thanks.
If you can switch on your video, then it will be okay. Yeah.
Right. So thanks for inviting me, and thanks for that kind introduction. In terms of, it's great to be a part of the 5th session of the Anemia Mukt Bharat webinar. It's great to see how, in a very systematic approach, Ministry and the partners are looking at various components of what needs to be addressed in terms of strengthening the Anemia Mukt Bharat program. Everyone in the nutrition community is so excited about the kind of potential and the unprecedented traction that nutrition has been getting with the Poshan Abhiyan, and specifically on anemia with the Anemia Mukt Bharat that has been there for now over 2 years in India's context. Before going ahead, also would like to wish everyone health and safety in this time of pandemic. I think it's very important for us, our near and dear ones, in this critical point of the epidemic. If you see my first slide, I've put something which captures the amount of funding and resources. The previous slides, the introduction slide, yeah. If you see the graph at the top, I think this stays with me since the time I've started working in nutrition from 2008 onwards. And at that time, if you saw the amount of resources that was coming in onto the nutrition as an area, it was less than 1% of the total funding, whereas if you from the ODA funding. But if you look at the impact that undernutrition has, we all know that globally around half of the under 5 mortality is with undernutrition as an underlying factor contributing to that whole scenario. And some of the latest work in India's context gives much higher number, over 60-65% in terms of India's scenario. So if we know that it is such a critical underlying factor for under 5 mortality and so much morbidity, and then cognitive development loss and the impact of the future, it's sad to see the abysmally low investment that nutrition gets, not just in one geography, but this is from the overall, from the global perspective, from the global scenario, I would say. Next, please. This slide, I'm sure like we all have seen, read, used, and whatever aspect of nutrition we are doing, it is linked with this somewhere or the other. It gives a very good, and this came out in 2013. So one snapshot in the first slide was 2007-8. What was the investment scenario at that point of time? 2008 Lancet came, 2013 Lancet came, and we had very clear kind of a framework that was available in terms of what are the immediate underlying and various causative factors we look from the nutrition specific and nutrition sensitive side. So not going into detail on this, but I think just to put this upfront that investment needs to be there for nutrition across all these aspects, which has been the kind of a critical factor of discussion at the global level. And in India, I say we are fortunate to have almost evidence-based interventions across both nutrition-specific and sensitive interventions, and many of these are very high in terms of the government priority right now and even in the past. Next, please. But before we go on to the next slide, I would say that improved nutrition has kind of been proved to be give high returns for what the world's development challenge has been, as we hear from the Copenhagen consensus statements and all. But the issue that comes out many a times is what proportion of health budget spent on nutrition, that kind of remains unclear many a times at the global perspective, from the global level. So if you look at the 2020 Global Nutrition Report, it recommends countries to develop costed plans that accounts for the effectiveness and the cost effectiveness of nutrition interventions. Use allocative efficiency analysis across the key interventions and across the geographic areas. Considering the cost sharing of other interventions, public-private partnership, and continuously tracking the spending that is linked to the performance monitoring and evaluation. So I think it's been the Global Nutrition Report gave a good kind of a framing around funding, not just for implementation, but also looking at it from the tracking perspective, evaluating and monitoring how the performance has been going on. And I think that's an area where Anemia Mukt Bharat, again, highlighting what I said at the start in terms of the way it is looking at it in a very systematic approach, has been quite interesting and exciting. Coming to this slide in terms of who needs funding and for what, I recently read this and I like the way it's been structured in terms of individuals. We all see like it at the household level in terms of the procurement and other things. Government in terms of funding their program, emergency relief, agriculture related investments in terms of feeding programs, fortification program, micronutrient supplementation program. So all these come under the funding that government is providing for nutrition. Then comes the private sector in terms of whether their product development, research, formulation is there, or in terms of their the trade capital they need in this whole process, the equipment, infrastructure development. Very critical in this journey that we are doing is the whole academic and the scientific research and development, which looks at the staffing as well as your resources that goes into the research, and civil societies and NGOs, of course, which mostly is in terms of the providing the TA support. Next, please. Quickly coming to what are our global targets that we are kind of trying to address by having all these funding going for the nutrition program. So globally, we know about the World Health Assembly targets, and if you look at the World Health Assembly Target 2, it very clearly focuses upon the reduction in the anemia at the global level. And World Bank has done a recent, and my apologies for some kind of a shifting of tables up and down in this that's happening, some formatting issue. But when you look at the whole thing, there has been very critical costing that was done in 2015 when they took the baseline of all these. What is the 2025 target, where we are in 2015, and what interventions need to be scaled up, and what it would entail in terms of costing for those interventions. So these are the various interventions. When we look at the interventions for anemia, it goes across micronutrient supplementation, mostly iron, folic acid, even multiple micronutrients, staple for food fortification, and of course things around the diet diversity and other aspects. So most of our intervention in by 6x6x6 Anemia Mukt Bharat strategy fits quite well in terms of the prioritized intervention that we have here. If you go to the next slide, I'll just link this with the kind of a costing and the benefits that we have. Next, please. Just click 4 times. So one more. So when you look at the benefits of achieving these WHO targets of 2025, anemia very clearly gives you the kind of quantum in terms of 265 million cases saved and 800 child deaths averted. What does this mean in terms of the costing? And that's where I'll go to the next slide. Looking at the entire WHO targets and the costing work that the World Bank did, it was interesting where they looked at over a period of 10 years, it will need something around 69-70 billion US dollar overall for driving these various components. If you click once more, that's the whole focused on the anemia in terms of the costing from the global perspective when they're looking at achieving the WHO targets by 2025. And this comes to roughly around 13 billion US dollar in itself. Our investments like food fortification, IFA supplementation, prevention from malaria, also kind of what comes very critically beyond those to me is the last 3 rows, if you see here, which is on monitoring and evaluation on the policy development and capacity building. I think that's also very critical aspects that it has to be looked at from the global perspective in terms of the funding, but even in our as we are entering into our next year's PIP development in every state in India, I think it's very critical from that perspective as well to look at whether states are investing on these components or not. Only then they will be able to know about their journey, where they are and how they are moving ahead. Just the way in terms of routine immunization and others, we see there is a regular kind of an assessment that helps in terms of driving these components. States would really benefit to track even anemia programs on each of these components. Next, please. And one more click. So here was what another tool that World Bank has around the called the Optima. But what goes into is looking at the various risk factors, what mortality leads from anemia, as well as what are the various interventions that they did in their modeling exercise when they went into the allocative efficiency. Next, please. So globally, we have a lot of kind of modelings available in terms of if you go from the investment, what would it lead in terms of improving in terms of coverage, what health impact it leads to, what is the budget impact, and what is the economic impact. There are various sort of tools available in this whole ecosystem list. I did mention in terms of the previous slide, as it said, that what coverage leads to what impact, and when we use it, it gives us a modeling. What I'm interested is the tool, something like if you go to the next one, the Optima tool. Next slide. Yeah. So when you look at the Optima, the way it looks at the whole allocative efficiency around the nutrition work, it's quite critical because what it does is it considers the allocative efficiency of spending across interventions that can impact malnutrition. It gives you modalities around what will, for example, how can a fixed budget be allocated across various nutrition anemia intervention to minimize the anemia and associated condition. It can give you examples around which interventions would receive priority additional funding if there were any more additional funding available at the national level or in a state level. If a multiple region analysis is being done, so which, like across various states in India, which geographic regions should get priority additional funding if our aim is to address the anemia as a burden. We can even have through the Optima model kind of a projected future scenario, like what will be the trend of anemia changes under different funding in terms of the increase in the intervention coverage scenarios. We can even set target. If this is what we have to reduce in terms of anemia for any state or at the national level or any geography, any set of states, how close is our country or these states likely to get to these nutrition target with the current level of funding, allocation according to the current expenditure, what is the current level of funding, reallocation that needs to be done optimally to achieve those targets. Also in terms of what is the minimum funding that would be required if and for which intervention if we have to achieve some of these targets. So we many times end up having targets for this is what we want to achieve, but I think it is important to also look at from the perspective of tail in terms of the resources for us to get to that number. Next, please. Yeah, and very interestingly, there is a set of multiple partners who come together and work in terms of the nutrition financing related aspects. This is a kind of a summary of some of the findings that IFPRI had done when they looked at the new NFHS numbers and added it to the budget of nutrition programs across WCD and the Ministry of Health's interventions that are there. When you look at this, India across these two ministries work normally kind of it needs around 38,000 crore rupees from the national and state budgets to drive a lot of it. Most of it is, or more than 50% is approximately going for the supplementary nutrition program as such. If we look at achieving the kind of target that we have, if we have to address a 50% reduction, I think we have to make that reduction across all the districts and states, and it would not be possible only by reducing in few states and few geographies and few districts. That's And I think one thing very critical, the second point here was to look at the low cost interventions and or rather the low hanging fruit interventions and start driving it. It was great to see in 2018 with the Poshan Abhiyan additional resourcing coming for the National Nutrition Mission. I think there is a huge opportunity that we start then looking at all our nutrition programs from these perspectives in terms of when we look at what is the need and what is the cost around those from the unit cost basis and total cost for each and every state. Then looking in terms of the what is the availability of fund, what is the current allocation and how it can be improved. And last, additional along with that is in terms of the utilization of funds. How do we look at the efficiency of allocation, effectiveness of the spending that's happening, as well as prioritization of where is the funding going. And partners like IFPRI, CBGA, Accountability Initiative, GHS, PHFI, a lot of these have come together and brought a lot of those R4D. These have brought a lot of learning across multiple states. So I do feel we have a rich amount of information how to use not just what needs to be funded, but also in terms of what can be taken ahead in terms of what has been funded and how it has been utilized as well. Next, please.
Yeah, Dr. Alok, sorry to interrupt. Just a reminder that we need to keep up with the time.
Sure. Last slide from my side. Next one. Yeah, so just wanted to leave with four additional components here in terms of PIPs, I think, and development of PIPs are the most critical opportunity that we have at national and across the states where we can get nutrition into the whole prioritization and which aspect is missing in what state. And I know in Anemia Mukt Bharat, this analysis has been done for various states, and I think it's great. It hardly exists for many other nutrition programs. So can we leverage it to fill those gaps is critical. Also in terms of Anemia Mukt Bharat, how we have it across in terms of systemic approach, that lens is critical and very useful. Last two components is in terms of we always talk about more nutrition, more money for nutrition. I do feel in India there is a strong case in terms of how do we get more nutrition out of the money which already is being invested across different programs. Like for IFA, what really is being utilized out of what is being given to the states for utilization. And last but not the least, with the COVID, I do feel that looking at this budget and the economics of spending and all those aspects comes out very prominently because of how much resources would be available going ahead for various intervention. I think that's important so that we don't go into the backsliding going ahead. Last slide, next one. Thanks. So I do feel nutrition is an investment that must we all must put a lot of weight behind it, and the time is for it is now more than ever before with the COVID having its major impact on the nutrition going ahead. Thanks.
Thank you, Dr. Alok. Thanks a lot. Perhaps Dr. Alok has quite comprehensively given a global context and the backdrop for the webinar. So next on our panel is Dr. Bk Mishra. I would like to, next on our panel is Dr. Vani Sethi, but unfortunately she won't be able to join right now. So I would like to invite Dr. Ms. Avi Seni, Consultant IAG, to present the presentation on planning and approvals, framework results, and support to AMP planners.
Thank you so much, Khobeb. Am I audible?
Yeah.
Okay. Good evening, everyone. Thank you, IG, UNICEF, and CPR for giving me this opportunity to present this work. Dr. Vani couldn't attend today, but I would thank her for setting the vision and giving the guidance throughout this piece of work. Starting with the presentation, in India, 15 core interventions are delivered through health system. The nutrition interventions are embedded in various health programs in National Health Mission's umbrella. They are budgeted as well as delivered as part of those programs. However, evidence suggests that for investments to translate into effective public service delivery, regular tracking of program finances throughout the policy cycle is vital. But programmatic know-how on these aspects is limited, as Dr. Alok has also pointed out, and it is important to track and act for improved financial efficiency. In 2018, Anemia Mukt Bharat was launched by Ministry of Health and Family Welfare under National Health Mission integrated with broader agenda of nutrition, health, and development through Poshan Abhiyan. Out of the 15 core interventions that are mentioned in the slide, Anemia Mukt Bharat covered 6 of those interventions delivered through health. Since AMB provided separate financial resources, guidelines, and involvement of multiple stakeholders, it gave an opportunity to design a framework for tracking and supporting programs' financial efficiency. Next slide. Next slide. Yeah. So, financing is a key block of health system strengthening to achieve universal targets. And it is one of the key building block of the whole system strengthening framework given by WHO. However, evidence mostly focus only two aspects, that is more investment and expenditure. In a systems approach, all the four aspects of planning, allocation, disbursement, and expenditure determine the efficiency of program financing. And hence, it is possible to explore financing in a systems approach and more closely work with policy making. Since Anemia Mukt Bharat provided these platforms, we have attempted to design a framework and have implemented in the prospect of Anemia Mukt Bharat to see if it works. Next slide. To support the additional cost for intensifying efforts, the Anemia Mukt Bharat guidelines mentions a resource envelope of 109 lakh rupees per district per year for several activities like procurement, capacity building, demand generation, etc. We looked into the budgets of Anemia Mukt Bharat to answer one question. That is, to what extent financing was a constraint to achieve 100% key performance indicators of Anemia Mukt Bharat throughout the budgetary cycle, that is, planning, allocation, disbursement, and expenditure. With this motivation, we designed this framework referred to as Track, Act, and Track, in short, Tata T. It has 5 phases. Firstly, the budgets planned and approved are compared to estimated budgets required for 100% coverage. We'll see how we come up with the required budget. This tracking should be completed by July such that the planning gaps can be addressed and demands can be raised in the supplementary budget proposed by the states. The second phase consisted of actions in terms of information sharing on gaps, advocacy, and support through meetings, trainings, and sharing tools to track budgets. In the third phase, the disbursement of approved funds are to be assessed in terms of timeliness and equity. Based on this, suggestions to improve timeliness and equity of disbursement would be shared in the fourth phase, along with developing tools for the same. And finally, the fifth stage tracks expenditure of the approved funds. So today, we are sharing first year results, that is from July 2019 to June 2020, of designing and implementing this framework to assist union and state governments across 12 states in improving the first two components of financial efficiency, that is planning and allocation for Anemia Mukt Bharat. Next slide, please. So we relied on two key data sources linked to NHM planning and budgeting process. That is PIP, which is planned budgets by states, and ROPs, which are approved budgets by the Ministry of Health and Family Welfare. First of all, we listed 11 major and 46 minor budget heads under Anemia Mukt Bharat on the basis of their relevance to the 6 interventions that focused Anemia Mukt Bharat. The snapshot of identified major budget head is presented in the slide. Few indicative minor heads with FMR codes are also shown. Detailed list can be available on AMB dashboard. Required budgets were calculated by multiplying denominators. So now denominators are available on AMB dashboard. We refer to them and we multiply them by unit cost and as per the norms given the guidelines and approved by Ministry of Health and Family Welfare. For components such as ICBCC, research, innovation, etc., where norms are not available to calculate required amount, proposed amount by the state was benchmarked as required. And Hello, am I audible?
Yeah.
Sorry, I think there was some network issue. So as I mentioned, how we have calculated the required amount, and then we compared the planned, approved, and required budgets to understand the extent of gaps. Next slide, please. Yeah. One second. Yeah, sorry. So these are the results. So we found that the major gap was in planning stage, as states proposed for only 36% of the required budget for 100% coverage. While allocation gap was only 17%, the overall gap was as high as 70%. We found that none of the states proposed for all the components of Anemia Mukt Bharat, and several states did not plan for important budget hits like procurement of hemoglobinometers, IFF for women in reproductive age, ICBCC, etc. Next slide, please. In this slide, you will see that the gap also varied state-wise. So the largest planning gaps were in Uttar Pradesh with 86%, West Bengal, Gujarat, and the largest allocation gaps were in Telangana, Chhattisgarh, and Bihar. Now, there were few reasons why the states were not able to budget for the AMB at scale. So one of the limitation was that there was incomplete information on budget heads, denominators, and cost norms. Secondly, the resource envelope is limited mostly, and which also limits both union and state governments to budget at scale. Lastly, though analysis is for 100% coverage, in practice it is also important to recognize that states may have different objectives while planning. For example, we found that states where the coverage of key program indicators was low usually proposed lower and probably more realistic achievable targets. Components like WRA were not rolled out in few states, and there were issues in supply chain mechanisms like unavailability of suppliers or delayed procurement. Next. So having undertaken this tracking exercise, the next important step was to share findings with state planners and enable them to use the data for decision making. Simple to use Excel tools were developed, listing all major and minor budget heads, denominators, and cost norms under Anemia Mukt Bharat. Templates for budgeting ICBCC, printing, and Center of Excellence, which were not available earlier, were also developed and shared with states. Actions to address gaps also included advocacy in supplementary financing cycle. So states also propose additional budget in supplementary PIPs, and we advocated there to include the missed items or under budgeted items. At the time of 2020-21 PIP submissions and NPCC meetings also, state-wise fact sheets with highlighting the gaps, items missed, under budgeted items were shared with ministry and states to ensure that budget allocations are adequate. Next, please. Yeah. So in 2020-21, which was the second year to implement this framework, we compared the budgets planned and allocated and see if there were any changes. It was found that both planning and allocation gaps reduced. States planned for 67% of required budget in 2020-21 against 36% in the earlier year, and 96% of the proposed budget got approved. One caveat is that the total required budget also reduced in 2020-21 due to reduction of fixed cost and presence of unspent balances. Next, please. You will see in the slide that the state-wise planning gaps also reduced in 11 out of 12 states. Except Bihar, all 11 states reduced the planning gap. Madhya Pradesh planned for more than 100% of the required budget. while Maharashtra, Jharkhand, Telangana, and Gujarat had the lowest planning gaps. Telangana demonstrated highest planning gap reduction of 44 percentage points. Now, what were the reasons why these budgets got improved in the next year? So, first of all, that the states proposed funds for more components in 2020-21. For example, Bihar proposed for 7 new components, while Jharkhand, Telangana, West Bengal, and Madhya Pradesh proposed for 4 more components. While all the 12 states improved the target population by a certain percentage, Madhya Pradesh, Chhattisgarh, and Telangana led the way by proving that budgets can be planned for all beneficiaries. So they planned budgets at scale. Next, please. So sharing with you a few milestones of this work was that first of all, the planning and budgeting was included in the AMB trainings and review meetings. Um, and secondly, uh, the planning and allocation support was extended for all 36 states. We did that earlier for only 12 states, but as per the request of Ministry of Health and Family Welfare, we extended this support for 36 states in 2019-20 and 2021. Next slide. We also replicated this framework to other nutrition interventions such as maternal nutrition, and similar to AMB, support is extended to maternal health division with tracking maternal health related FMR codes and sharing gaps. In 2021, reduction in overall gaps was also observed in maternal nutrition budgets. Next slide. At state level also this framework was replicated. For example, Jharkhand had started tracking progress of interventions like NRCs against budget allocated, and program reviews also now include the expenditure progress against ROPs. Next slide. So this framework also explains that when you give an idea and if you can show it that it works, then give the cost and support and advocate for cost and operational guidelines, which help states in planning more efficiently. Next slide. So finally, some major insights of this whole work was that the key gap was in planning stage itself. States needs to plan and demand for adequate funds if nutrition programs are to be delivered at scale. Requirement of fixed costs such as training, procurement, these costs reduce with time. So if planned adequately in the initial years, budget requirement can be optimally managed. It is also understood that there are ground level challenges in targeting budgets at scale, but cost estimates of full coverage helps policymakers in knowing the extent of planning required for the program. And having fixed and comprehensive budget line items shared with all the planners helps in comparing the budgets allocated and inform policymakers to plan efficiently in the following years. As for the next steps of this work, it is important to understand that improved planning and approvals, though critical, may not immediately lead to improvements in program coverage. Analyzing other components of financial efficiency, such as disbursement and expenditures, and assessing gaps in state schemes, can further enhance the long-term impact of this framework. Lastly, just to wrap up, next slide please. Just to wrap up with some important learnings, first of all, the availability of guidelines, disaggregated data, unit cost, and denominators is critical for such an exercise. Secondly, tools and templates help and should be combined with training and advocacy. Furthermore, an appreciative and non-fault finding approach with government and providing programmatic insights for addressing procedural bottlenecks throughout the year were very important. The involvement of several partners helped generate critical mass, which was necessary to obtain buy-in for applying the Tata T framework. That's all from my side. Thank you all for listening, and we look forward to your questions. Over to you, Kobe.
Thank you, Avi. Thanks for explaining how the PIP analysis was done for all the using the Tata T framework and how the gaps were addressed and advocacy was followed up with the ministry to address those gaps. Second on our presentation is Dr. Rajeev Srivastava. I would like to invite Dr. Rajeev Srivastava for his session. Dr. Rajeev Srivastava has an extensive background in health program planning, capacity building, and public health management. He has vast knowledge and experience of almost 32 years in performing high quality strategic health program planning, budgeting, monitoring, and evaluation activities. He has supported several activities aiming to improve quality of health services and has been instrumental in leading so many groundbreaking works such as development of integrated referral transport system, state-specific Anmol software, and upgrading the budget and fund management system of health departments. Dr. Rajeev on his medical degree from 1978. I would like to invite Dr. Rajeev Srivastava for his presentation. Thank you. Okay, so perhaps Rajeev Srivastava will be available with us in a moment or two. So Dr. Bk Mishra is there? Apni? Yeah. So Dr. Rajeev Srivastava is there. Okay, welcome Dr. Rajeev Srivastava. But your voice is not audible to us.
Am I audible?
Yes, sir. Now you're audible.
Okay.
Okay, sir.
So,
please continue.
good afternoon, and thank you to the Institute of Economic Growth for providing me the opportunity to present the initiative in the state of Madhya Pradesh. Can I have my presentation, please? Yeah, next, please. Well, if we talk about the Anemia Mukt Bharat component, in the state PIP, we have budgets in many of the heads of NHM. The biggest chunk of the budget that we have is under procurement. Then we have budget under capacity building, community interventions. Next, please. IEC, BCC, monitoring and evaluation, research and surveys, program management, state level HR, innovations. So we have budget under this component under almost all of the heads of the National Health Mission. And the biggest challenge as regards to Anemia Mukt Bharat is that the activities are implemented at the field level, and there is a need to provide the control of the budget to the field officers, that are the BMOs who are working actually at the community level. So Madhya Pradesh has devised an online disbursement system for disbursement of the budget, and we use two applications for the management of this budget. The first is the MP Aushadhi application for the procurement of drugs and consumables, and the second is E-Vitta Prava that we use for all other activities of the program. So each activity is again assigned to a DDO for implementation, and the budget and fund is available directly to the DDO. So we provide the budget directly at the level of the DDOs, who is the BMO in the field. And all transactions are made through a single bank account at the state level, and all transactions are online. Next, please. Now in this slide, I want to show the process flow of the procurement budget, how we use the procurement budget. Uh, it's an application called MP Aushadhi, and all procurement, the procurement process is decentralized and all procurements are done through the Madhya Pradesh Public Health Services Corporation. The drug specific indents are submitted to the corporation, and the corporation does the rate contract for all the uh, required procurements. Then district wise budget allocation is done in MP Aushadhi as per the approval of the PIP, and again the purchase orders are made by the district CMHO store. So the rate contracts are done at the state level and the purchase orders are placed at the district level. Then the amount is calculated at the field level, and again the quantity is blocked at the district level. The payments are made directly from the district level to the suppliers. Next, please. So, if we want to conduct an assessment of the disbursement of funds under the AMB, uh, we can do so because we have the guidelines for procurement, for trainings, for printings, for various activities under the Anemia Mukt Bharat program. And we have these online applications, the eWith Prava, which is available at ewith.nhmmp.gov.in, and the MP Aushadhi application. Next. So actually, now I want to talk about the eWith Prava application, which we use for almost all activities under the Anemia Mukt Bharat. Uh, The objective of this application is to ensure timeliness and equity in the disbursement of funds. So MP ensures timeliness and equity up to the DDO level. Mostly the budget allocation is done up to the district level in all other states, but in Madhya Pradesh, we ensure this equity up to the DDO level. The budget is allocated online as soon as the PIP is approved, because we have the activities mapped, all activities mapped under the PIP are available in this application. So we can allocate as soon as we get the PIP approvals. The allocation rights are with the state program officers, and the state health society has delegated the right to the state program officers, so no approvals are required for allocation of the budget. This allocation is done directly to the DDO responsible for implementation. The district authorities can see what budget has been allocated to their DDOs and they can monitor, but they are not involved in allocation process per se. The funds are released separately under two heads. One is beneficiary and other is the global. The beneficiaries activities are for direct payment to the beneficiaries and the incentive that is paid to ASHAs. All other vendor payments are categorized under the global activities. The request for additional budget or funds can be made to the state program officers directly through the application. Next, please. So this is how we manage the budget and fund disbursement through eWith Prava. We get the budget from Government of India. It comes in to the State Health Society, and the funds are kept in a single parent account at the state level. Then we have various child accounts of this single parent account, which are the DDO bank accounts, and then beneficiaries and vendor payments are made through these child accounts. I'll explain the process, how this process goes, and then a summary of expenditure is generated. So the features include a single bank account, a web-based application for management of the funds and the budget, and a single window gateway for all payments. The information is available real time for fund availability as well as for the expenditure. Next, please. These are the various users of e-Vittaprabha application. You can see the at the block level we have the BMOs and other field facilities. Then at the district level we have the district hospital, the CMHOs, the medical colleges. Then at the higher level we have the regional joint director offices, the training institutions, and at the state level we have program officers and the policy makers. So all these users have login for the e-Vittaprabha application, and they have their defined roles to play in the management of the budget and funds. Next, please. This is the process flow of e-Vittaprabha. Uh, I like to emphasize that e-Vittaprabha is an application which is integrated with PFMS, because all central government funds are mandatorily to be disbursed and expenditures are to be made through PFMS. So we have integrated the e-Vittaprabha application with PFMS. So first thing is the beneficiary or vendor registration. This registration is done in e-Vittaprabha, and the registration process flows into the PFMS, and the beneficiary or a vendor gets registered on the PFMS application. Then a unique code is generated and funds can be distributed. On the left side, we can see how these activities are mapped. The budget heads, they are mapped for different activities and sub activities. The funds are allocated to activity wise to the DDOs. Now the process is that once a bill is received by the maker, at the DDO level we have three types of users. The first is a maker who is an accounts person. Then there's a verifier who is a program manager, and then the approver. So mostly the block medical officers, they are the approvers for the fund expenditure, and the block program managers, they are the verifiers. Once the accountant receives a bill, the payment is processed in e-Vittaprabha, and this process then a bill is generated, an expenditure is then it is forwarded to the verifier. The verifier, on the basis of the actual information of the program that has been implemented in the field, verifies the payment, and it goes to the login of the approver, and it is approved. Once a payment file is approved, it through an SFTP server goes to PFMS. Then the actual payment happens through PFMS, and the uh, fund is deducted from the state single bank account. Again, the report of the expenditure of the payment comes from PFMS to e-Vittaprabha and is shown in the login of the DDO who has made the payment. So it's fully integrated, and it's also integrated with other applications like for tax payment. Uh, uh, the payments can be made for income tax, for service tax, for GST. So these applications are also integrated. Next, please. These are the various reports that are available on the e-Vittaprabha portal. We have a dashboard for the state program officers. We have a dashboard for the DDOs in the field. We have separate dashboard for monitoring. Then there are reports for analytical reports for fund disbursement, for budget management, and the program officers, they can also analyze the expenditure vis-a-vis the physical achievement in the field. Next, please. These are some snapshots from eVitprava application. This is how the dashboard looks. There's an information regarding the budget allotment, the fund release, the expenditure till date, and there are some expenditures in progress. So all this is visible on the dashboard. Next, please. This is the state level dashboard where the finance division can monitor the advances, the performance, the financial progress, and it can also see which DDOs are utilizing the funds in a better way. Next, please. Uh, this is a report in eVitprava where we can see different budget heads, the activities are mapped, the budget allocated, and if there's a request for a budget, then we can see a request and where the request is pending with which user of eVitprava and what action is. So this is the entire process, and this is an analysis. Next, please. This has an activity wise analysis at the program officer level. Next. This is another report. Yeah. Uh, Now I come to the benefits of this eVitprava system. It has ensured uninterrupted availability of funds until the block level. It allows us the flexibility of budget allocation. The program officers can directly allocate the funds as and when required to a particular DDO. We can reduce a budget if a particular DDO is not utilizing the budget, and we can increase the same for the another DDO who requires the budget. So budget allocation can be directly done by the state program officers. We can monitor the utilization of the funds, and it ensures improved and unbiased implementation of beneficiary oriented schemes uh, and also the ASHA incentives. Uh, Minimal advances are required because it's through a single bank account. So we always have liquidity of the fund available. It's integrated with the state ASHA application and other applications for program monitoring. And the limits can also be imposed for various planned activities. Next. Now, when we developed this application, there were several challenges. The most difficult one was integrating it with the PFMS, because PFMS is a Government of India application, and there were a lot of complexities regarding the FMR codes. Uh, we had to match the various activities with PFMS, and finally we could do it. Then Uh, there were it was a big application, a very heavy application was built. So load estimation, infra sizing for hosting in the state data center, that was also a challenge. Categorizing of various activity types according to the PIP and the PFMS. uh, then, because it's of dynamic requirement, every year we have some new activities in the PIP. So it's dynamic. So we needed a flexibility in the software that we can map new activities, we can delete activities. That all has been incorporated. Then financial statement, ledger management, we have integrated it with tele also because accounting was required, so it's integrated with the tele application. Payment of taxes was required, so it has been integrated with those applications. Then hardware was required, but we have a good state data center in Bhopal, so we could host this application there. Next. Then there were challenges for rollout. There were around 450 users throughout the state of Madhya Pradesh. Then upload of PFMS. uh, During integration with PFMS, There were several challenges regarding the data of payment that came back to Evith Prava. So we had to struggle a lot with the PFMS and NIC teams at the central level. Then they were finally integrated. We have also integrated it with state ASHA and HRMIS applications. Then when we implement an application in the field, connectivity issues are there. Connectivity was to be ensured. Then some financial decisions had to be taken, like closing of the district level bank accounts, the field level bank accounts, because now we are working through a single bank account at the state level. Next, please. When we implemented this application, we had to provide training. So we did a TOT at the state level, and then these trainers, then they went to field. They trained the field staff also, and we also provided hands-on training at Bhopal and at the district level. Connectivity issues were there, still persist at some of the nodes. Then the payment, when it is authorized by the approver, there's a biometric device and it's Aadhaar integrated device. So there were challenges in biometric device maintenance in the field, and Aadhaar authentication is required whenever a new user is registered in Evith Prava. So that is also to be done. Uh, then there are some DDOs, as happens in the field, because it's a financial management application. So we had to emphasize on the security issues like the password policies and the use of digital signatures. Uh, Again, one thing happened. Was the role of the district program officers. Now, because the funds and the budget was given directly to the field officers, the district program officers somehow felt that now they don't have a role to play in the financial management, so their role had to be redefined. Next, please. So now, because this application is now running well in the state of Madhya Pradesh, uh, and it is now implemented for the entire NHM activities. Uh, and now we are also looking to about regarding implementation of the same for the state aid society, then for other applications. So it's scalable because we can handle a large number of users, and it's easily adaptable application, and it can be sustained. It serves like an umbrella platform where various financial transactions. Evith Prava has been recognized as a best practice when we have the best practices summit at Kaziranga. It's quite a user-friendly application. So I think it is well sustainable, and the ministry has also explored possibility of implementing it in other states also. Many state NHM units have also inquired and tried to build similar applications for their budget and fund management. Uh, Next. Thank you. That's all regarding this e-with Prava and our budget and fund management that we do for the Anemia Mukt Bharat program in Madhya Pradesh. Thank you.
Thank you, sir. Thanks a lot for explaining e-Mita Prabha system and how it has simplified the disbursement of funds, and also sharing the issues and challenges you faced while implementing the system. Now, I would like to invite Dr. Uma Mahadevan. An urgent meeting has come up, so she needs to leave. So I would like to invite her to kindly share her insights. Dr. Uma Mahadevan, please.
Thank you. Am I audible?
Yes, ma'am.
Can you hear me?
Yes, ma'am, sure. Before ma'am start, a brief introduction of ma'am, I would like to share. She's in the IS currently posted as Principal Secretary, Panchayat Raj, Government of Karnataka. She was previously Principal Secretary in the Departments of Women and Child Health Development, Karnataka, during which time she introduced important new initiatives in the state maternal nutrition, early childhood, and disability sector. She has worked in planning, agriculture, education, and health sectors in the state and in the atomic energy sector in Government of India. She was a member of the working group that prepared Karnataka's first human development report, and she also writes on development issues and culture. Yeah, ma'am, please.
Yeah, hello. Am I audible? You hear me?
Yes, ma'am. Yes, ma'am. Please go ahead.
I'm on a internet connection, so actually I've been off and on trying to listen while working, trying to listen into some of the other panelists speaking, but I have lost internet in between. Hello?
Yes, ma'am. Please go ahead.
Yeah. So I am not really going to speak about the financial mechanisms for Anemia Mukt Bharat. I've noticed that there have been other speakers who've gone into some detail on this. However, what I wanted to really emphasize was that in financing for nutrition program and Anemia Mukt Bharat, we need to emphasize the role of convergence, and we need to look imaginatively at the possibilities for convergence. Sometimes department where we implemented the primary program, there was ICDS, and we also had state programs, like a program for children in Anganwadis and schools, as well as a hot meal program for women and breastfeeding mothers. We have a program of egg for Anganwadi children. So that was mainly direct nutrition interventions, along with various other efforts at improving infrastructure, providing pure drinking water, sanitation, etc., to the and improving really the general feel of and the fact that women mothers were coming to the Anganwadi every day made a big difference. And we've taken up a program actually to ensure that all of the state's Anganwadis are their things with proper infrastructure, drinking water and toilets and so on. And wherever they need their own buildings, there is a significant proportion which still needs their own buildings, but planning to saturate and complete in a phased manner in a short time. But after moving to the Department of Rural Development and Panchayat Raj, it's become much clearer to me that there's tremendous potential and also need for convergence of different efforts in improving nutrition access on the ground. For example, one of the biggest potential programs for convergence is Mahatma Gandhi Narega. In Karnataka, we're using Mahatma Gandhi Narega in a very, very focused way, working on converging with Finance Commission grants at the level of the Gram Panchayat, also converging with Panchayat's own sources of revenue, which are considerable, and with CSR funding. We have also, for Northern Karnataka districts, a regional development board called the Kalyan Karnataka Development Board, which was created under the Constitutional Amendment for Article 371J. And there too, because these are high burden districts, we focus developmental funds on better infrastructure, as well as program funding in Anganwadis, in schools, and in residential hostels, where taking up a big program to plant nutrition gardens under Mahatma Gandhi Narega, to plant nutrition gardens, to create compound walls, playgrounds, toilets, and so on, and really create a kind of a complete infrastructure around schools and Anganwadis where possible. This urgent funding of the panchayat, we also have functioning. The Anganwadi committees, which are chaired in Karnataka, they've been structured, and they're chaired when I was in Women and Child Department, restructured the Anganwadi committee to chaired by the of an Anganwadi child, have other pregnant women and breastfeeding as members, also have a father of a child, at least one father child attending the Anganwadi, and one of the grandmothers of who are attending Anganwadi, as well as the panchayat, local panchayat ward member, worker, the Anganwadi worker, and any other adolescent girl from the panchayat, from the jurisdiction of the Anganwadi, as members of the Anganwadi committee. Now, this committee meets on the third Saturday of every month. It's called the Bal Vikas Committee. It has formally made a subcommittee of the Gram Panchayat under a specific. The Gram Panchayat has 3 standing committees, one of which is the Standing Committee on Social Justice. So the Standing Committee on Social Justice has as one of its subcommittees the Anganwadi Committee, and therefore the decisions and requests and issues, problems faced by the Anganwadi Committee are straight away brought to the notice of the Gram Panchayat in a very systematic manner. In addition, we have the same is the case with the School Development Committee, same with the Village Health, Nutrition and Sanitation Committee, all of which are chaired by stakeholders, and where the concerned panchayat ward members are represented as well. So this is a kind of a structural thing where we have framed bylaws, published the bylaws, notified the bylaws, trained these committees in their functioning, and also we've conducted training. We've also published FAQs and a little handbook for them to function. These handbooks, copies of these handbooks, are also going to be placed in our rural panchayat libraries so that they are there, because members may come and go and we may not conduct the training programs in step with every single change in membership, but the relevant handbook to which they have to refer. The long and short of this is really that funding is extremely, I mean, it's something that's entirely possible, not only at the state level, but also at the panchayat level, because the panchayat does have access to a reasonable amount of untied funds in terms of finance commission and state grants, and also their own sources of revenue. Karnataka panchayats, for example, last year managed 96 current demand in terms of property taxes and other revenues. But also that Mahatma Gandhi Narega is an extraordinarily flexible program, which not only adds to the incomes of local agricultural labor, especially women, but also provides ways for panchayats on the ground to function better, to plan their local assets better, to fill infrastructural gaps, and of course to provide employment. And I think the real learning for me has been that apart from all the convergence that we try to push at the state level, by looking at different kinds of program funding that can be put together, there's a certain convergence, and there's a very powerful convergence that happens on the ground at the level of local governments and Gram Panchayats especially, which become when they are sensitized to their responsibilities and to their needs, to the needs of their local people, especially the needs of the women, the pregnant women, the breastfeeding mothers, and the young children in their areas. And as part of this, we also developed in Karnataka a technology application called Sneha, which was a solution for nutrition and effective health access, which actually converged both the health and the nutritional surveys conducted by the ASHA worker and the Anganwadi worker every year, converge them so that there would be less chance of people getting excluded, less chance of pregnant women, breastfeeding mothers getting excluded by falling between the two surveys. We merged the two surveys and also made it a tool for better functioning, better planning and functioning on the ground by Anganwadi workers. There's a part of it which pertains to young children, but there's also a part of it which pertains to pregnant women, tracking their nutritional status, their hemoglobin, consumption, and so on, both which are relevant both to ASHA and Anganwadi worker. So these are of the things, initiatives that managed to push. But when these initiatives get visible, when there's visibility at the panchayat level, visibility to the panchayat about the need, what can be, I think there's an extraordinary amount of readiness. There's a tremendous amount of readiness to do what needs to be done and to find innovative on the ground, which really is more encouraging than anything we can even push from the department level. Much more innovative than anything that we can from departmental silos. That's pretty much all I had to say. I didn't have anything in particular to add about financing. Though, of course, I will say this, that when we were in WCB, financing is something when you have to dip into state resources. You have to recognize that this is a priority. So there's that amount of advocacy that you have to do, that this is a priority, that this is the best way to use this amount of resources and push. If you make it a priority that you want to reduce malnutrition by a certain amount, then you have to spend on direct nutrition interventions. It's not that you just keep measuring and expect things to change. Monitoring and measurement is one part of it, but you also have to put that extra funding into direct nutrition interventions. You also need to look at how you can create a kind of a generally beneficial cycle. For example, the money that we spend, the state spends on, say, the milk program, providing milk to 1 crore children between the ages of 6 months and class 10 every day, 5 days a week. It's called the Shira Bhagya program, but it also, it not only gives valuable protein, calcium to children, but it also puts a certain assured income in the hands of farmers, dairy farmers, and especially women, because women are the majority of people who actually care for the cattle and get this income. Karnataka being the second largest producer of milk in the country, it's beneficial both to the children and to the farmers. So those kinds of programs work very well because it becomes easier to advocate, and it also helps the agricultural economy in general. With the egg program also, we're trying to see how women's groups, NRLM women's groups, can be trained to have small, distributed, decentralized centers of poultry production to deliver eggs to Anganwadis, also fresh vegetables. So these are kinds of innovations that not only make the funding a little more reasonable and manageable, but also add to capacities on the ground and also enable governance and development in a way that that doesn't just happen by pushing it at the departmental level. So that's pretty much all I had to say. Thank you very much for having me, and congratulations on this excellent initiative. As always, Avni, it's a pleasure to talk to your audiences. Thank you.
Thank you, ma'am. Thank you for highlighting, for sharing your insights and highlighting the need for deep diving into finance and the importance of advocacy for finance. Thank you. Now I would like to invite Dr. Bk Mishra. Sincere apologies, sir, for keeping you waiting. We had to accommodate Dr. Uma because of urgency. Dr. Bk Mishra is the State Program Officer, AMB, State Health Society, Bihar. He's a medical graduate with PG Diploma in Public Health Management from IIPH Delhi, and he has a 30 years of working experience in public health. He is currently State Program Officer in Bihar for AMB and National Tuberculosis Program, Elimination Program. Thank you, Dr. Mishra. Please, I will share your PPT at my end. Thank you.
Yeah, thank you. Good afternoon.
Good afternoon.
I don't know how to proceed because the very elaborate presentation by Dr. Rajeev Srivastava on the successful e-Vitta Pravah and e-Aushadhi, everything, and whatever Madam said, the Principal Secretary, Karnataka government, that wisdom and insights. So my presentation could have been better because it is very much preliminary presentation if had it shared it earlier. So, but the sequence has been reversed probably. So, but still there are learnings. And so coming to the point, can you start with my present first slide? So second, please go ahead. Next slide. Yes. So let us summarize in a way that how the fund allocation and utilization timeline, all these things are the normally happens whenever there is no corona. So we have to go through the normal, we can say normative flow. So every year in the December, PIP preparation and submission for the next financial year is done, and all these things has to be done. So then what we are already doing the similar exercise in the last week of the November. So rather it was the PIP meeting where the DPMs and the DPCs have come from all the 38 districts in the hotel Patliputra Continental. They have been doing. And I hope that by in the first week of December, we will be able to prepare the final thing with and discussion with our MD NRHM. So then again, this is sent and the discussion is done in the month of January. It may be that this year it may come earlier also. A revision of the activity if it is required as per discussion during the NPCC meeting. So then again, the NPC post NPCC budget is proposed and sent after making the changes that happens every year is not new thing. So then the ROP, what Dr. Avi said to us that ROP comes, means the approved budget. So proposed budget we are doing, we are working on the proposing the budget for every activity, for every service, for every drug, items, everything. Otherwise, we will not be able to translate into the action or the implementation. So the ROP, when the ROP comes, so then the collation of the fund from the AMB program, and then in the May, the fund allocation under each FMR codes is sent from the state to the districts. Now here, just I would like to say it may be easier in other states, but is somehow not very very clear, because the program is the new. And if you see the different FMR codes of the drugs, so something and is under the NRA, RBSK, something in the child health component, something in the maternal health component. So the AMB program as such, can you tell me that is there any FMR code where the AMB cell has been dedicated specifically? I have not seen even the last year, and not seeing even in this proposed PIP plan what we are doing. So we say that the convergence and all these things, it should happen. We are working on that. But for a newer program, this clarity that how much control in a SPO of the AMB program has over the different heads, that has to be implemented by the different program officers. So with the clarity that Dr. Rajeev Srivastava was saying that the SPO will allocate the budget directly to the DDO to the bottom, directly to the, say, the block level DDOs. So, but how much a state level program officer of the Madhya Pradesh in the Satpura can understand about a Majhauli block of the CD block, CD district, or somewhere the system is stronger in the Indore division. So Indore, so of the sub district. So that it will take some time to learn, and we will see how the budget allocation and expenditure has the less inequality between the districts having the different profile and different geographic distribution in the Madhya Pradesh and Bihar and the other difficult areas also. So June, then if it is sent to the block level, then July to March. So July to March is basically the time where the block level people start working. In our state, it is again a different story. There is a challenge, but can you move to the next slide, please? Sir, please next. Yes. So fund allocation and utilization flow from the state to block level. So preparation of the district-wide AMB fund allocation to the financial guidelines in the prescribed format, and retaining some budget at the state level. So this is very normal, and what is being done in our state. And then the submission this to the PIP cell for final compilation of and ED review. So our MD NRHM, or the executive director of the this state health society, he reviews, and I have also witnessed that he sees even the budget financial guidelines in the local language, and sometimes he corrects that no, you can, this is the grammatical error or everything. I have never seen, I never expected that people can go to that level at a higher level, but he sees there are people who are seeing the financial guidelines, and the same is sent to the finance cell, and then the budget is dispersed to the districts from the our finance cell. It goes to, and then the districts receive the fund along with the district-wise allocation sheet and financial guideline. They take some time, and then the district program management unit at the different districts, they allocate the same budget and the guidelines. They don't change usually the guideline, because the guideline, whatever has been is prepared by the state health society, is more or less becomes a financial constitution for them. No one tries to deviate from that. So probably most of the cells, they do not, districts do not have the freedom to amend the guideline without the knowledge of the executive director NRHM. So, but the distribution to the block level, this is done. And then the civil surgeon also reviews, and with the DPM and the DAM and everything, and then it is dispersed to the budget is dispersed to the block BMOs, what you were saying, that the DDOs. So in our state also, so MOIC, medical officer in charge in the different blocks, they are the DDOs. And the PFMS is really working everywhere. So there is no, and probably not even in the JSY, everything is going through that. And DBT, we are doing, PFMS, all these things. Of course, there are challenges. So sometimes more challenges because of the PFMS also. Because the smaller amount and the where the define everything is not defined, so it becomes very much difficult to pay them. So if some coolie worker is coming the petty cashier, so it becomes a challenge, and that is why you will see that the budget allocation and the budget utilization is one thing, but when it comes to the expenditure, reported expenditure, I mean to the state and society of the FMG group, it reflects that, okay, so budget was allocated 40%, it was almost utilized 35%, but the reported expenditure, what comes to the electronically to the financial state level finance cell, it says 10% or 20% because it was not reflected into the reporting. So these are the hiccups that makes us difficult. Also, we are trying to overcome. And now, so recently, we have started the finance management cell has started giving the feedback to the districts in the different programs, the different FMR groups. So what was the target and how the financial feedback, that is very much encouraging, although even I do not understand much, but I'm trying to cope it. So the districts will learn somehow that someone is watching the expenditure on the regular basis. So now come to this is very simple slide. It looks from surface, but there are different things between the lines. So major fund allocation and AMB program in the 2019 and 20. So IFS syrup with auto dispenser. So whatever budget was approved under the ROP, so percentage of fund utilization was about 40%. And the same way, IFA pink, it was 32%. So there were regions that the program was implemented in 2019, almost in August. And although the financial guidelines were sent, the drugs reached up to the blocks, but even for the auto dispenser, the nursing staffs, in spite of the trainings, so in the field, the ASHA has to train to the mother. So these were the things that took the time to percolate deeper into the health system, and it takes. So 40% and 32% this was, and the district-wise IFA requirement was calculated and shared with the districts. All these things happened, and one thing was good that the training, although it was not very much a larger amount, but 94% of the training budget was the expenditure reported to be spent. And this happened because the state level trainings were done at the state level, then at the district level and the block level. Everything calendar was meticulously planned and people were watching it. And then comes to the ASHA incentive. So in 2019-20, what the financial guideline was sent to the districts, actually the IFA pink and syrup were introduced in the July-August month of the 2019. And IFA blue tablet for the under the Rashtriya Kishore Swasthya Karyakram, it was launched a bit earlier. So when these things were going, it could have been a temptation at the program level that why should we give the incentive only for the syrup and to the ASHA, only to the syrup 100 rupees per ASHA per month, and only for the syrup when the IFA pink is also being introduced. So then the stakeholders were different. ASHA were responsible and easily they are moving in the community and talking to the mothers, pregnant women, children, but the ASHA has never been very much familiar to and going to the schools. So how can the ASHA be responsible for the non-implementation or under-implementation of the IFA pink tablet among the say 5 to 9 years children in the primary schools? So this year we made a correction that ASHA will be given incentive if they counsel the mothers, they distribute it properly, and they report it, then they will be given 100 rupees per ASHA per month. So, but somehow, unfortunately, the corona has affected very much differently to our program, every program, including the Anemia Mukt Bharat also. So, what is the challenges? I think it's the last but one slide. So we have already discussed the time delay in the allocation, because the budget allocation from the government in India to state, state to district, and district to block, and then it is not easier at even the block level. So even at the block level, the people have to implement something, and if you implement, then you have to spend something, and then it has to be reported. So it is not very much easier, only the delay in the allocation. So I can say just one thing, that earlier the medicine was experience-based medicine, and now it has become evidence-based medicine. The same way, this PIP preparation, budget allocation, earlier it has been for the years since the NHM, the population-based norms. And it was easier. We all were very familiar with making the PIP and budget allocation as a population based. But now the need is that planned activity based preparation of the PIP or the budget allocation, and then it has to be adapted. It has to be well understood at each level. That is very much challenging for every one of us. And I really appreciate at this side, before I forget, Dr. Avi Saini's presentation, that she said, emphasized very clearly that integrating the PIP a chapter in the training component. So it's a very much, it will be a paradigm shift, that we have been in habit of incorporating the training in the PIP, and here she is talking about the including the chapter, very dedicated chapter on the PIP in the trainings, and it is very much required because the PIP does not happen at once. So less time to utilize the allocated funds. We have already discussed online payment mechanism to ASHA. It's already has happened, but again, the reporting. So when we say that 70% of the coverage, is everything under the control of the ASHA? Then why this, is this not a different kind of inequality, that everyone knows that the corona has affected every activity? Even the ASHAs were engaged in this, what we say, containment zone activities and all these things. So has the government of India or the state level give any concession that, okay, this year, whatever has happened, our ASHA should get this 70%, this ceiling of the achievement of 70%. I know that no ASHA will be able to say that I have covered the 70% of the children, children under 6 months to 15-year age group. So such type of the activity, it will take some time. I think entry of the utilization in the wrong head, other factors. Okay, so please go to the next slide, please. Okay, so next slide. I think it's some, okay, so it's coming. So the adopting the online financial management information system, I was very much mesmerized about what Dr. Rajeev Srivastava was explaining, and if it is a reality in the Madhya Pradesh, and it appears because I have worked for more than 5 to 6 years in Rewa and Jabalpur and Sagar Sambhag as a WHO consultant for the RNTCP. So there were systems very much strong, and I pray that it should work, and it will be very much replicable. I will try to convince some of the things in my state also. So periodic reviews, of course, we have started reviewing financing. but then it is very much structured reviews. So when you have already decided that at what point you will review, what you will see, then people will learn what to show you. I have a different opinion on my side, that when you are moving for the review, let us, the way decentralized planning happens, decentralized implementation happens. So review mechanism should also start from the periphery. That if MOIC, we should develop a tools that MOIC should better review the performance every month, at least at the block level. Then it should be at the district level, and even if you review with semi-structured and professionally structured questions, I will say, because I have seen people making the secular trends, bar charts, comparing the districts with other state districts, scorecards, and can anyone say that these scorecards have motivated some of our program officers at the district level and the program level? So these are my lessons of the epidemiology, and whatever. But again, I salute to the Dr. Aviseni's presentation, Dr. Alok Ranjan's presentation, and we all will learn gradually how to strengthen the supply chain management. Supply chain management means when there is something in the campaign mode, like a diarrhea program, control of diarrhea, or deworming day, so, or the pulse polio, or some mass vaccination program, the health system or health field workers are very much trained to go to the having a drugs or equipments to the schools. But on the regular basis, when has been that the health government staffs or the field workers have been carrying something on a regular basis and getting the report on the regular basis from the schools? So we will take some time to learn, or should, if there is an urgency, and there is urgency, so we should think in a way that can we adopt some different routes, engaging the private care private under the PPP program, that some of the districts or the schools where the some NGO or some will be engaged for reporting, and also the supplying mechanism. And so these will be the many lessons which I would like to learn from the program. Thank you very much. I hope that I took already more time. So if there is a question, I would like to answer. Thank you very much.
Thank you, sir. Thanks a lot for sharing your insights. We'll probably skip the question answer session, and now I would like to invite Dr. Sandeep Sharma for his session. Dr. Sandeep has done his PhD from JNU, New Delhi, and MPhil in Applied Economics from CDS, Thiruvananthapuram. He specializes in the area of health financing, and presently he is working as a senior consultant and heading the health financing division of NHSRC, and leads the team involved in producing yearly national health account estimates for India. Before joining NHSRC, he was working with PHFI in the area of health economics. His area of interest includes health financing, decertification in health, and equity issues in healthcare. I would request Dr. Sandeep to keep his presentation crisp and within the time limit, because already we are running short of time. Thank you. Please continue.
Yes. Thank you, Mr. Ahmed. Thanks for the introduction. What I'm going to speak is a bit different because I don't directly work in the area of nutrition. But at the same time, I would say that this session so far has been a learning session for me. But the topic that I'm going to talk upon is whether we can integrate nutrition health system financing. Next slide, please. So many of you must be aware that there are 6 blocks, building blocks in WHO when they talk about health system and service delivery, health workforce, information, etc. I don't want to go into details, but the point I want to emphasize that they have realized that financing is one of the important component among all the other things. Now, when we talk about financing, next slide, please. Basically, though it can be broken down to some more subparts, but basically it's about how the money is collected, resource mobilization, where it is pooled, and where it is dispersed. Now, in case of health, there are new provider purchaser division has come, so now government is also purchasing health services. But earlier it used to be only provider. But this financing system, it kind of gives you background to what kind of health policy that we trying to have for a country or for a state. Because if it's a government prepayment system based on tax, then of course the equity is an issue, or we are going for a insurance kind of system where it's again depends on the ability to pay, or we are going for social insurance kind of system. This I'm emphasizing why, because once we have understanding of this kind of system, then it also helps to understand how a financing is taking place at the system. Next slide, please. So in NSRC, what we do is we produce a national health account. Basically, it summarizes that in a
Perhaps there is some connection issues. We'll try to get back to Dr. Sandeep. We are trying to connect to Dr. Sandeep, and meanwhile, I would ask everyone to be patient, and in few minutes, he will be able to join us.
Hello?
Yes, sir. You're audible, sir. Please continue. Please continue.
Sorry for that. I just lost the connection. Okay. Now coming to the point that the national health account that we make, basically what it does is kind of summarize the financing system that we have in the country. So basically, we look at the who is paying for the money, the source of revenue, how it is paid, where it is put in different health scheme, and for whom the money is going and for what. although the idea behind giving the fund flow of health sector, also it helps us to get a very robust estimate for health expenditure for the country. Next slide, please. Now, in terms of how we are going to integrate nutrition care in health financing. Now, financing for nutrition is bit difficult in a sense that defining nutrition itself is very difficult. As first presentation, I was looking at that slide on health expenditure and nutrition expenditure. The high expenditure on health and nutrition also. I was thinking maybe the expenditure nutrition is also very strongly positively correlated with expenditure health. So high expenditure nutrition might reduce the out-of-pocket expenditure on health. So that kind of correlation do exist. So given that fact, how to capture the nutrition expenditure data is challenge in itself. In health accounts, that exercise that we do, basically we look at expenditure, health expenditure across the department, even the WCD. So we only take those are related to the health. So it's kind of very limiting that way. We are not being able to take many of the things which are actually going for nutrition, because as per the methodology that we follow, nutrition is not something we take as a direct benefit for the health. So it goes out of boundary. But there is one more tool which we have not yet started in India, but with coming of data, probably coming years we will start. It's also called a disease-specific health account, which is where not is just the money, we also look at the kind of disease where the money is going, whether it's a government expenditure or private expenditure, etc. So maybe that will give us an idea, how much expenditure or how much investment taking place for nutrition, both over nutrition as well as under nutrition. So we have to take into account both. Thirdly, we have data on out-of-pocket expenditure by NSSO, etc., where again, probably to some extent, disease due to undernutrition can be captured looking at the money going for what are the out-of-pocket expenditure for different diseases. So these are the limiting way we have been able to integrate nutrition. But as such, if you have to bring in nutrition overall in the health financing system, I see, I might be wrong here, but that some of the problem that I see is what is the definition of nutrition expenditure itself? How to get the right definition so that we actually capture the how much expenditure is taking place on nutrition, and again capturing across the department. Some of them are direct expenditure, some of them are indirect expenditure. I know there has been expenditure sensitive to nutrition, etc., has been taken place, but actually quantifying them, it's a challenge that has to be that needs a lot of discussion and actually define what is the nutrition expenditure. Again, the other problem that we face is again there is limited evidence that we have both at the national and the state level. How much is the nutrition expenditure? Like for instance, if I look at a budget, if I just take in a nutrition, that is like almost I will be taking 40 or 50% because nutrition is also taking place at Ministry of Health, Water Supply and Sanitation, and as some of previous speakers have also talked about convergence. So even if you have to design a financing system, we have to take into account this convergence. But at the same time, I would like to say there has been some budget tricking exercises I've come across. I think Odisha, I think government of Odisha has come with a budget for nutrition, which is a very interesting initiative where they have tried to culminate expenditure across all the department where whatever they're spending on nutrition. I think then there are some studies on Rajasthan where I think even accountability initiative was part of. So there has been ways where they're trying to get the some sort of estimate for nutrition expenditure, but the challenges remains that how to get the right estimate. And one of the biggest challenges is that getting the sources of funds right. Now it is not just the government expenditure. You have to have a a holistic financing system, as we are doing, as I said, in the National Health Account System. If you want to have a holistic financing system incorporating nutrition, we need to capture sources of fund, central, state, and whatever the private expenditure. Now, as I have already mentioned, getting assistance for different government departments, that itself is a big exercise that as we see how it can be done properly. And third is what about household contribution? The household is also paying for nutrition, but how are we going to capture it? How are we going to get this expenditure for nutrition? So this kind of, although there are work based on the consumption expenditure, etc., but when you're defining nutrition expenditure, these are some of the challenges which I foresee needs to be addressed. And as term of integrating our nutrition in healthcare, uh, again, I was going to the nutrition report 2020. One of the suggestion is we can integrate nutrition with universal healthcare, primarily with the primary healthcare, which I think is one of a good idea because investment in nutrition actually might reduce out-of-pocket expenditure in many of the diseases on the long run. So it does have a reason that it can be incorporated. And secondly, probably some of the health intervention and linking with the nutrition intervention and village health nutrition day, which is under NHM, which takes is one of the classic example. So maybe this kind of incentive intervention should be rethought of and how to bring in nutrition in those programs. I think that can also help so that nutrition gets integrated in the mainstream and that will also process in the long run also have that convergence that we have been talking about is achieved. Like one of the previous speakers also talked about Manrega, like employment, with agriculture, all of them has this nutrition component ingrained in it, which makes it difficult to, I say, to complete, but at the same time, they have an important role to play. And I think if we can do that, even at the policy level, that is a very nice way of integrating nutrition in overall development discourse. I'll end here. Thank you.
Thank you. Thanks a lot, Dr. Sandeep. Perhaps you have quite beautifully explained what all needs to be taken into account for defining nutrition financing and how the quantifying the nutrition expenditure is a major challenge across summarizing nutrition expenditure across different programs and through different departments. Thanks a lot for your insights. Now I would invite Ms. Abni from CPR to kindly continue with the session.
Because I'm waiting. Thank you so much, Khobeb. Big thank you to all the attendees as well, and I apologize that we've had to skip the question and answer session. I would request the previous panelists, though some of the questions have come in the Q&A box, so if you could just type in your answer so that at least some responses are given. We'd like to move on to the next session. So we've heard a lot from people within the government, and it's interesting that one of the questions, in fact, talks about what is the role of development partners in program budgeting. And so we're delighted to invite the next set of speakers. To start off with, I'd like to invite Dr. Luigi. Dr. Luigi is the Chief of Health at UNICEF India Country Office and has over nearly 20 years of work experience in the international development sector. He has vast experience in contributing to the design, planning, implementation, monitoring, evaluation of maternal, newborn, and child health policies and programs through either long-term assignments across the globe, from Angola to Cambodia, Sudan, Mozambique, or through even short-term pieces of technical assistance in numerous countries in Asia and Africa. So Dr. Luigi, we'd love to get your thoughts. We've heard through the day experiences that Avi shared on behalf of the study team on the importance of tracking and the Tata T framework. But I'd like to particularly ask you about the importance of having such frameworks and the replicability of a framework, and what can partners, development partners like UNICEF and others do as well, so that we get, as Alok started, we get our financing right for nutrition as well.
Okay.
Thank you so much.
First of all, thank you so much for having me with you today. I've gone through 1.5 hours of lectures, really. in all directions. So very useful to be here. And also, this is not my usual group of colleagues. I come from the other side of the moon, which is more the health sector, in this virtual division that we have between the health and the nutrition community, that I find personally a bit systemically wrong. So before I get to your question, I'd like to share a few much broader thoughts. One is, we are within a system that even before the pandemic that has hit us, has shown a systematically low health expenditure as a proportion of the GDP in the country. And that has mean essentially that the resources available through the public sources to the health sector are barely sufficient, if not insufficient, and B, a cause of both vertical and horizontal inequities across states, districts, blocks, and communities, and across various programs as well. So to start with, the envelope at which we are all looking for various programs is not ideal. And this is before the pandemic. Then COVID comes in. When COVID comes in, it brings a couple of major issues if we look at financial efficiency or financial planning. One is countries are facing major economic crisis. GDPs are going down, so we do not know how the allocation to the health sector will be going forward, be it India, be it everywhere else in the world. Chances are that the allocation to social sector will be suffering from this crisis. The second, and this is more talking to planners, is that we are, of course, in an environment of extreme uncertainty. And when you are in an environment of extreme uncertainty, it's clearly more difficult to plan because you don't have your key parameters are being questioned. The third is that the health sector is under extreme pressure. So your resources, your inputs, your human resources, your hospitals, your facilities, your ASHAs, it's all under pressure to deliver against something exceptional. Now, within this context, being efficient in planning becomes even more important than in a normal context. And in here, I'd like to, and apologies for being very generic in my thoughts, but I think efficiency in planning has to go, at least within the health sector, beyond nutrition interventions. I believe that your team speaks to nutrition interventions as loudly and clearly as it speaks to interventions that are more, if you want, typical within the health sector. At the end, planning is one exercise and is one skill set. And if the skill set exists, it will work across programs. If it doesn't or requires improvement, then it applies across the board. So what do we need collectively and including partners to do to sustain a more efficient planning in the sector? I think the first point before going into efficiency is about effective planning. And effective has to do with a few things. First, know your gaps, where your bottlenecks are. Second, know your priorities and your targets. Third, know your capacity. How much can you absorb? How much can you deliver? Because sometimes systems are not yet tweaked, and that's a generic statement, to absorb a certain amount of resources across the board. And then we move to efficiency. And I think it has been very well presented throughout. There are examples, there is some evidence to what UNICEF has contributed, which was presented earlier in the session. I want to make again a very obvious statement when it's about what do we need for efficient planning. Probably so obvious that I haven't heard about it so far. The first thing you need to plan effectively and efficiently is managers. And management is not a given skill set that you assume that is there. It requires investment in capacity. And it requires, I believe, an effort to building this in every pre-service training going forward for all the providers, workers, policymakers that work within the sector. Without that, we are not giving at the start the right weapons to those who have to plan, from the last community up to facilities, to blocks, to districts. We need to give them skill sets. And I think this needs to be a medium to long-term ambition at which we need to look at including partners. And then talking to a much more, if you will, a simple and short-term oriented approach. There are very simple things that can be done. And I think, again, that the examples shown earlier have clearly demonstrated guidelines, simple tools, even in the form of simple Excel spreadsheets, can really help to visualize, contextualize, and plan better. Data, be it targets, denominators, unit costs are essential. Cost of packages are critical. So the basic pillars can be introduced and should be introduced. And of course, I keep reflecting, coming from a country that is of the size of probably Rajasthan alone, that if you want to introduce these simple tools systematically across what, 7,500 blocks or more, you need collective engagement. One tool, one voice, all the partners on board. Otherwise, the task is overwhelming. The other thing where I see a role for UNICEF and other partners as well, speaking to the previous example of how introducing simple interventions as improved planning, is to expand these and continue investing in going beyond planning into the stages of allocation, disbursement, expenditure, and then looping the feedback up into the next planning cycle. So I think the evidence we saw needs to be moved further down the cycle. To conclude, and that would be, I think, my recommendation to this group is, whatever model you have shown, and I've seen many very successful models or systems or examples, the first is to expand the model. So make it broader, make it larger. 12 states can become 27. So expand it across the country. The second is to expand it horizontally. If a good practice works for a nutrition program, it can probably be equally working or in helping finance or planning for financing MNCH intervention, a malaria intervention, and immunization intervention. So again, planning is an horizontal skill set, and if something works, bring it horizontally across the sector. The third and last is, all of this needs to be linked systematically to results. So as soon as we see the linkage between inputs and outputs, the better it is to make a case both for nutrition and for other interventions, to make a case of, okay, I need more money here, and I can prove it that it works. By giving me this amount of funds, I've increased it this much my coverage. This narrative needs to be speaking to your advocacy for nutrition, financing for nutrition, and to everyone, every program's advocacy when it comes to financing for nutrition, for maternal, newborn, and child health and nutrition. Over from my side, thanks again, and a good continuation.
Thank you so much. I think you've given us important advice as well, that go broader, both geographically, but also horizontally. And that's exactly what we hope to do. In some ways, this is a framework and a methodology, and the hope is that it can be adapted across sectors, across states as well. And so thank you so much for your comments. I'd now like to invite Dr. Mita Chaudhary onto the stage, as it were. Mita is an associate professor at the National Institute of Public Finance and Policy, which is an autonomous research institute. She's a graduate in engineering with a PhD in economics from the Indira Gandhi Institute of Development. She's been working on public financing for health at both the central and state level. And her recent research is focused on the fiscal space for health and public budget management, particularly looking at the National Health Mission. We, for one, have really benefited from reading all your studies, Mita, and really look forward to hearing your thoughts as well on NHM.
Thank you for inviting me for to this webinar. Excellent presentations and also a lot of learning for me. I know we have already crossed time, and I'll be very brief and just make 4 points, not take more than 5 minutes on this. I think to begin with, I think I would just first like to make the point, I think, and the introduction itself, was extremely appropriate, and also the presentation. Some of the presentations also mentioned this point, that I think the quantum of budget is not so important. I mean, I would not say that it's not important, but I would say at the moment we would have to accept that there are constraints on the overall resources, particularly in these COVID times. And what is important is to really make the best use of the resources available at hand. Dr. Ravi's presentation made this point that the finally sort of approved budget is much smaller than what is usually the proposed budget by states. But if I look at the NHM experience of the approved budget, of the amount of resources that is usually approved, only about 55 to 60% of the funds are actually used, which means you actually do not use even 40% of the approved budget. So in that sense, I think it's important to focus on the utilization part to a very in a very strong way, because even with these low approvals, we know that our resource envelope and the spending is very low, but even at this low level of this resource envelope and the approved budget, we actually end up spending only 60% of that. So I think it's extremely important that we focus a lot more on the quantum of budget. While the quantum of budget is important, how we actually utilize these funds. Now on the utilization, I think there are various stages at which, and there are various kinds of hurdles that I see that really, poses, problems in utilization. First, if you look at, in fact, particularly in this particular program, I was looking at the budget and I realized that more than 2/3 of the budget is actually on procurement. And if I look at the utilization of the procurement component under the National Health Mission, it's one of the actually the lowest among all the different components. So, it's extremely important in this particular program where you have a very substantial amount budgeted for procurement, that the procurement processes are often enormously complex and time consuming the way it's done. And that really reduces the ability to utilize these funds. So on the utilization, I think to start with, I think even at the planning level, I think it's extremely important. I think various speakers have already made that point, that even at the planning level, it's extremely important that we plan the budget in a manner that we can actually utilize it. The optimal allocation of resources across different components. If you look at the overall, overall utilization pattern under NHM, there are certain components which states have been able to use much more easily than other components. And so the optimal allocation of resources across the components is important. Besides, I think the allocation in the NHM, also in this particular program, I guess, is as usual the bottom-up approach, where the frontline workers are actually the ASHAs, the ANMs, and the Anganwadi workers. Now, I think, there's one point which really, concerns me, is that, these frontline workers are not only for actually, they have a number of, they have responsibility of a number of programs, not only for the Anemia Mukt Bharat. So as a result, you're really, you're loaded with a number of responsibilities, and the effort and the capacity to plan across these programs very effectively. Often we know that this planning is not really done at that level, and it is often done at the block level, or even at times it is even done at the district level. But I think, the capacity to plan optimally in a manner that you can actually utilize the funds is very important. The second part of the utilization, second part that really sometimes poses a hurdle is the flow of funds. There are often delays in the approvals at the central level, but I must say that the approvals at the central level has really improved. Now all state approvals are usually done by March, where earlier it used to be done only by at the end of first quarter or so. So the approvals at the central level has been expedited. However, I think there's a substantial delay still in releases of funds from the state treasury to the state health societies. It's just because of a very complex, complex administrative process through which the approvals has to be done, and the release of funds has to be done from the state treasury to the state health society. Now, once this money reaches the state health society, and I think in this context, the MP experience, I think is extremely important in today's presentation of how, if you have a single account at the state level, how the problem of further releases to, lower tiers, you don't need specific releases. You have a single account, and all, even at the lowest level, one can actually withdraw funds from a single account, which reduces the delays in releases from the state level to bottom down. So I think that's a very important experience, and we should be exploring a little more and see and explore the replicability of this in other states, whether such an efficient system is possible. I think the third point that I think I would like to make is that, we should remember that unless we have a well-functioning health system, because an individual program, a vertical program cannot run individually very efficiently on its own. If there are vacancies of HR, if there are capacity issues in planning, implementation, actual expenditure, how you actually incur expenditure, the overall efficiency of the health system, I think, is extremely important in ensuring that it actually works even for each and every program, because there are a number of programs under NHM. So overall, you can see that if you look at NHM experience, again, you will see that states which did not have a well-functioning health system found it difficult to absorb funds, because unless you have a functioning health system, all of this work through the health system often. And the final point, which I think I should raise, which which I've always felt in the context of NHM, but is also, this scheme would also be affected in that, is the fact that that I think we focus a lot on very detailed budgeting, a very disaggregated level of budgeting and monitoring, 1,500 budget lines at times, very specific FMR codes, etc., which makes the system very rigid and often, less flexible. I think we should, think of ways to, make the budgeting a little more comprehensive and list and a little more sort of, built in together rather than really disaggregating it at very, very minute levels of budget head. And in fact, if you look at the NHM experience again, of the 55 broad heads, I think that it had till about 18, 19, you could use, you were actually using only most of the allocation in about 10 heads. So, you could actually club a lot of heads and bring in a lot more flexibility and reduce the rigidity in the budgeting and the accounting process. It also consumes a lot of what time within the health system, while accountability of public funds is absolutely important, but the level at which one needs to think of, in terms of budgeting, in terms of, providing flexibility, is something which one needs to explore a little more carefully. I think I would stop that. Thank you.
Thank you so much, Mita, for your 4 succinct points. And what's interesting is something that you brought up, which also came across through all the presentations, that even within India, there are so many examples of practices that do work. So often when one thinks of financing as a topic, it's all the conversation sometimes veers towards our resources enough. But I think today what was interesting was that we heard the entire chain of financing, right from planning to fund flow to actual disbursement and utilization. And through that journey across all the presentations, we heard examples of how things are working in different states. So with that, I'd like to invite for closing remarks. We're delighted to have Dr. Sheila Deb with us. Dr. Deb is currently Additional Commissioner, Child Health and Nutrition in charge in Ministry of Health and Family Welfare. She's completed her MD in Social and Preventive Medicine from All India Institute of Hygiene and Public Health, and has an MBA in Healthcare Administration from the Faculty of Management Studies. Dr. Deb, thank you so much for joining us and sitting through the entire presentations. And we know that we've gone over time. So thank you so much for your patience, and we'd love to hear your comments.
Thank you so much. Thanks to IEG and UNICEF and Accountability Initiative at Center for Policy Research for organizing this important webinar. And it was a very thought-provoking webinar, and the discussions were very interesting. What I understand that all the experts, right from the very beginning, Dr. Alok Kumar, Dr. Abhi Shaini, Dr. Rajeev Srivastava, Dr. Uma Mahadevan, and finally, Dr. Sandeep Sharma and Dr. Luigi from UNICEF. So I have heard, yes, I have heard all of the deliberations. And what I find that I hope that all the participants have today has gone through all these presentations, and these expert deliberations have given us a very thoughtful insights into this topic, that is this increasing financial efficiency of AMB program. As we all know that increasing financial efficiency of any program per se is key to getting value for money in view of the limited resources. And there is always some limitation in resources, as Dr. Luigi has already and other experts have also pointed out. So we need to have a very, wise and wise planning, so that the resources those are allocated can be utilized to the maximum. I think that I thank actually Dr. Luigi, because he has actually comprehended all the discussions and all the that should happen at the end of this webinar. So all the speakers of this webinar, they have shared these important insights and regarding these various aspects of increasing financial efficiency in IMB program. There have been we have seen that there are many challenges that the states are even facing these challenges, and the states presentations from Bihar and MP, we heard how they are doing their best to face those challenges and to solve those challenges. At the end, I just want to just give some comments on on some points what I noted down regarding, as Dr. Sandeep Sharma, he was saying that quantifying this nutrition budget and getting the right estimates. So apart from the financial contribution towards the nutrition under different programs, actually it is a difficult exercise. As Dr. Avi was saying that in her presentation, she was showing that there are gaps between this approved budget and the required budget. So actually, here are some clarifications regarding this. What I thought that I will share with you, that whenever states are proposing for budgets, and then the final allocation of budget is being done from the center, and then these funds are actually they are not being utilized to the full extent because of different reasons, as Dr. Rajeev Mishra has pointed out, that the reaching of these funds to the down to the block or to the sub block level, so there it takes time. From March it becomes July when they finally get this budget. So essentially at that level where the expenditure happens, there is actually lack of time. It is not a year, but it's some 7 or 8 months at the max. So ultimately the financial utilization is actually not complete because of this time gap. So that's why, and some of the budget are being carried forward to the next year. So whatever it's being seen that the approved budget, actually there are some inbuilt budgets which we cannot see, like those there are some this carry forward budget, and there are also some state initiatives. The state puts some budget into the programs. There are local funds, so these are not reflected in this PIP or ROP. So that's why whatever we are seeing here, the 64% gap or 33% gap, maybe that actually that gap is not there, that not so much. Second is regarding this this AMB program has what I want to highlight, that AMB was launched in 2018, and actually it was implemented in September 2018. And so the states till now there have been the 14 states who have where the state level orientation could happen. So in other states it has not yet happened due to this COVID-19 pandemic. So those states they are trying their level best to put some of the components for financial allocation, but we hope that it will be done after, once this COVID pandemic peak phase is over. Then the states will we will be again some online programs will be happening to orient this the remaining states. But what it is the encouraging fact is that in 2019-20 the budget allocation was 748 crores, but in the 2020-21 it has increased to 830 crores. So they are, in spite of this this COVID pandemic, the states are trying their best to utilize their budgets, but there maybe there will be some some remaining budget that will not be utilized, as you all in detail it has been discussed today. So what are the challenges there also at the field level, at the grassroots level, so for implementation of this program. And also there is a big challenge in procurement also. So the third point, I want to highlight that the budget for the activities are proposed based on the on the coverage also, or the achievement of the states. For example, we have provided the budget as well. The first year we thought that there should be at least 50% coverage. So we provided budget accordingly. This is in consultation with the states, what the state plans, and then we provide budget. So and it, as Abhi has told in detail that this in PIB, it's a detailed PIB process. In the NPCC meeting, the state sits with the center, and there are detailed discussions how much is possible for them to cover. And then for example, as if we provide 50%, some of the states they have utilized to the extent of 20 to 25%. Some of the states could utilize budget only to 5 to 10%. So that means that there's coverage. This is regarding coverage. So if the coverage is such low, then automatically the budget is not being utilized. And then the next year when we are they are proposing budget, or we are approving budget from the central level, then we take into account how much they can perform, and accordingly we judiciously actually our target is decided for providing budget. So this is also in consultation with the states, not it's a one-sided thing. That the sole purpose of this program is to systematically improve and increase coverage, and for that purpose all the aspects have to be covered and have to be seen. And what the one example is this central procurement. Central procurement is for the 14 states who are chronically facing the problem of supply of IFA supplements. So the center now at the national level we are going for central procurement. So in this way, I hope that one by one we will be able to solve this problem, these challenges. And but here again, I want to highlight one thing, that we are on whatever we are saying, this is regarding the nutritional cause of anemia. So AMB is not only the nutritional cause of anemia. It is, we say that it is around 50% of anemia is due to nutritional causes. And even the CNNS data shows that there may be even, it may be even less. So in that case, because there's 30% cases the serum ferritin level was low. And so the other causes, what we are doing, and we are doing something is being done, but that means there are different programs like this fluorosis control program, hemoglobin programs for hemoglobin, managing hemoglobinopathies, programs for malaria control and control. So but we are not counting those budgets also, which are actually going for, which are actually benefiting this anemia prevention and control. But it is very complex, as we are already discussing that it is complex. It is a complex issue. There's anemia. So how the budgets are going through the different programs, that is also a complex mechanism that we cannot calculate the whole as a whole. But we need to see also the other aspects of anemia, where other means the other causes of anemia, and how much how the budget is going there also. So we need to focus on that area gradually. We this year hopefully we will be doing some exercises to see how we can improve the activities for non-nutritional causes of for prevention of non-nutritional causes of anemia also. So this is in nutshell what I wanted to share with you, my thoughts. Thank you so much for a patient hearing.
Thank you so much, Dr. Dev, and thank you so much for clearly emphasizing the role that coverage also plays. I think, as Dr. Luigi had also said, at the end of the day, it's all about results, and finances also need to be seen in terms of their ability to deliver the results. So thank you so much for that, and thank you so much for clarifying the process as well, and also reminding us that while the topic of this webinar was about Anemia Mukt Bharat, at the end of the day, if we go back to the results story, then we have to identify all the causes for nutrition, and hopefully frameworks such as those that were discussed today can be a starting point for that as well. Wanted to just say a big thank you to Dr. Dev, to all the panelists, and as well as the attendees for patiently listening to us. I know that we've gone over by half an hour, so thank you so much for your patience, and we hope you did enjoy the session. The recording of this webinar along with the presentation will be put on the AMB portal, which is on your screen right now. This was the 5th series under the AMB webinar series, and so do request everyone to go to the portal to see some of the others. There have been some fascinating ones, and we hope to join you for the next webinar series, AMB webinar series, sometime early next year, which will be about training as well. So thank you all, and have a good evening.
Thank you, Avni. Thank you.
Thank you.